Okay, so what I'm going to cover now is newborn at risk. And unfortunately, I tried to Zoom it and I had problems with my computer. So we will have to catch up on a session um, later on a Zoom. Hopefully, I can get it working right. All right, so where is it? Okay, newborn at risk. So some of the problems that we can see and are seeing is weight discrepancies. LGA, which is large for gestational age, and the terminology is medical or is macrosomia, and the weight is over the 90th percentile. In these huge babies that look like toddlers, that doesn't mean that they're necessarily healthy. And often it's due to mom having gestational diabetes and those high glucose levels. So some of the complications that you'll see is shoulder dystocia significantly. So that's the first thing you want to check for a baby that's over 8 pounds, 12 ounces, which is an LGA or macrosomic baby. So they would include your newborn assessment should also include gestational age. So at 37 weeks, these babies can be huge. So what is the gestational age of of this infant, and what are their glucose levels? You have to look at policies and procedures. Usually, if the baby is designated being over 8 pounds, sorry, 12 ounces, we're going to do blood sugars every hour for 3 to 4 hours. And we look for is the clavicle fractured? Any, was there any, did mom have spontaneous rupture of membranes? Was there any bruising? And if there's bruising, you'll typically see that there will be an increased bilirubin level because of that increased red blood cell breakdown, and the immature liver can't handle that. So on the opposite end of the spectrum, we have SGA babies, or small for gestational age, which are often preterm, and maybe they're small due to their genetics. However, they may have creases along their entire feet. You can really tell an SGA baby because they may have no creases at all on the feet, and their reflexes will be non-existent or slow, very weak, and they're not as alert. Okay, so uh, IUGR, which is intrauterine growth retardation. This might be the reason for their small for gestational age, and the small for gestational age is below 5 pounds, 12 ounces. It could be mom smokes, she has some sort of chronic disease, or there's a congenital or any placental abnormalities. So often these kids, you'll see them, they're really scrawny and the skin is just kind of hanging on them. Head is larger than usual, and the sutures. So it's important to palpate the sutures from baby to baby so you can determine what they're like. Some are large, some are small, some are wide. Abdomen, it could be sunken, the cord is really thin. They didn't get fed nutritionally or for whatever other reason, whether it be placental in utero, so they're very small. So this is what's called a Ballard score, and some hospitals no longer do them, but it gives you an estimate, a guesstimate of a gestational age according to um, how the baby can extend and move its extremities mostly. So over 42 weeks, that's what I call stay in the cooker a little bit too long. Um, those are 6 to 12% of pregnancies this day and age, though it's unlikely that the patient is going to get to 42 weeks unless she refuses an induction, because most often the provider will choose to induce the patient, and by that time they're sick of being pregnant and will agree to that. So shoulder dystocia again, if they're over 42 weeks, they've had more time to grow and get bigger. So again, you see that shoulder dystocia. And what happens to the cord as the pregnancy increases in duration and goes over that 40 weeks, it becomes calcified and dry. So therefore, you don't get good blood perfusion or oxygenation. And there's also decreased amniotic fluid, questionable maybe meconium aspiration if the infant is under any stress at all. So again, we look at gestational age. What are those glucose levels? And check that clavicle for fracture, any spontaneous rupture of membranes, bruising, increased bili. So over 42 weeks, there should be no vernixes as the infant goes into 40 weeks. All of that vernix, which covers the body, is washed away. Okay, and you'll see like peeling, drying, cracking skin, and all of that. So less than 37 weeks is considered to be a preterm. So these are the terminology: preterm less than 37, late preterm is 36. So, and you can read that for yourself. Very low birth weight, 3.3. So that's the terminology. So these infants that are born preterm end up having all kinds of uh, learning and complications on down the road, learning problems, poor motor behavior, hearing loss, and maybe lung asthma problems. So actually you can see they're very small, very, very tiny, and you might even be afraid to pick them up because they're so tiny. Very poor muscle tone. There's no fat tissue because that subcutaneous fat, or what's called brown fat, actually is made towards the end of the pregnancy. And so the thin, very thin skin, you can see through it for these really tiny ones. There's lots of lanugo, lots of vernix, so you can pretty much tell a preterm infant when it comes out because of those identifiers. There's no creases on the soles of the feet, and if you've done your head to toe assessment and you have felt the nipple buds on a full term infant, well, these infants don't have any nipple buds. There's just not there. It's flat. So you can tell just by looking at this one. I don't know if you can see it very well, but there's lots of vernix. However, this kid is pretty pink. But so just the vernix alone tells me you can be off by due dates. Remember, it can be plus or minus 2 weeks, so maybe it was actually 2 weeks early. So infections are a major issue with these premature infants, and this is an older one. Probably the price of taking care of and uh, a preemie these days is probably double what this is telling you here. Some of the problems that they're having. Obviously with respiratory, because the surfactant doesn't develop in the lungs until the latter part of pregnancy either. So there's no surfactant. The surfactant hold the alveoli in open in the lungs, so the infant can take the first breath, but then the lungs collapse because they can't stay open. So you see significant respiratory issues. Yeah. And then there's no coughing reflex there, so they can actually aspirate. Oh boy, immature respiratory system. Okay, in the control center, the apnea, a part of the brain that controls respiratory, so they might see apnea there as well. So some of the cardiovascular problems. Okay, so they're having difficulty transitioning, basically. So some of the things that you may see are like the foraminal valley doesn't close right away, or the patent ductus. We have poor circulation. Obviously, thermal regulation. There's no brown fat. What brown fat does is that's what the infant uses to maintain thermal regulation. It utilizes that. Um, if it has problems because of prematurity, there's no brown fat, and it has an increased metabolic need, so it's going to end up losing weight as well. It doesn't maintain any flexion. Okay, whoops. All right, wait a minute, what did I do? Their nutrition problems. So prematurity, you think small for gestational age or IUGR, blood sugars can be really low. So I already said, oh, I already went that far. Okay. So fluid and electrolytes, okay. They lose the water through that very thin skin. It's not enough to keep them warm. Okay, and the warmers, yeah, it's like sitting under the Florida lights. Fluid loss, so that increased metabolism again, okay. So you can see how it affects all parts of the body. And the immune system is very immature, so they don't develop that passive immunity. So they're really at high risk for infection because of those invasive procedures that we use. So gestation or near term, also called late preterm. Again, they have a lot of the same issues: respiratory, jaundice, feeding problems, hypoglycemia, seizures, and sepsis. So the cost is astronomical. And of course, like I said, this is probably doubled or even tripled by now. The March of Dimes at one point had a campaign out there for pregnant moms that one of the things that we had to educate the public on was to keep the baby in the, let's say, in the cooker or in the uterus as long as possible. That way it has an optimal chance of survival, laying down that brown fat, the lungs with lots of surfactant, putting on a good weight. Um, and they were telling them not how a lot of women, they're sick of pregnancy by the end of the pregnancy, and it was all the rage for a while to deliver the baby and get it over with by induction or C-section, whatever means possible. But that's not always what's best for the baby. What's best for the baby is to keep them inside in the uterus as long as possible. Oh, I keep going backwards here. All right. So this is just a little video that, I don't know, maybe I can click on it and you can see it. Or maybe just pretend. Oh, it's your big moment, by the way. They were almost friends. Tears on flowers for a while.
Sailing around by the way. Would you like to tell me something? Do you remember what she said? When I looked into your eyes for the first time. I know you looked quite ready. Nothing to forget. You saw.
Okay, let's see if I can. There we go. That was all right. So some of these premature babies, what we end up seeing is retinopathy, or problems with the eyes, retinal detachment, all kinds of eye issues. You see the little babies with the glasses, vasoconstriction of the immature vessels, and also a condition called necrotizing enterocolitis. That's why you measure the abdomens of the infant, okay? Because parts of the bowel dies is what it is. Okay, decreased blood flow to the intestines, leading to necrosis, perforation, peritonitis. So what you see here, the signs and symptoms, are the abdominal distension, increased gastric residual, bowel sounds, vomiting, blood in the stool. Okay, those are all not good things for a little tiny baby. And this is kind of a picture of what it might look like. You can see the inflamed bowel. And this is all the dead bowel in here where you see the black. And so this is how it shows up in the infant, the enlarged abdomen. That's why those babies in the NICU, we want to measure their abdomen, and they look kind of jaundiced too. So another thing that we often see is congenital anomalies, cardiac anomalies. If, as you can see, and you probably learned in A&P, the normal flow of blood, oxygenated and deoxygenated blood, as it goes through the heart and mixes. Okay, but here we've got a problem. This is with ventricular septal defects here, and mixing blood from oxygenated and right deoxygenated ventricles. There's a problem down here. Okay, so in patent ductus arteriosus, okay, and coarctation of the aorta, those are just a few, and you can read more about that in detail in your book about that. Another major one is tetralogy of Fallot, okay, where you see pulmonary stenosis and narrowing of the artery, which overrides the aorta here, hypertrophy of the right ventricles. So that's what my aunt had. And then there's transposition of the gray arteries too. The aorta and the pulmonary arteries are reversed. Interesting. The infant can go through surgery for that if they live close, hopefully to a hospital that is close by. It can be resolved, but sometimes, even though they have surgery, they may not survive later. So other congenital anomalies, this is why we look at the back and we look at just above the tailbone to look for neural tube defects. So this is something that you might see that's identified with spina bifida. Okay. So you want to look and visually look. In the hydrocephalic, where you have a very large and enlarged head, actually my niece had this, and it wasn't identified until later. So that can create all kinds of neurological and other complications. So remember we measure the head. So congenital anomalies, you'll see like the most familiar one, I believe, is Down syndrome or trisomy 21. So when we're doing our assessments on our babies, we're looking to see do so do the eyes line up with the ears? No, don't look at my keyboard. Do the eyes line up with the ears? The bridge of the nose is flat, and they don't have a good muscle tone, and their tongue is really big for their mouth, and they often are like pushing their tongue out. That look for the simian line, you can see it in the lower bottom part down here where it's really large and it's up here. It goes all the way across. And anytime you see the word syndrome, there's not just one complication, there's several complications. Not only heart, but these infants have kidney complications and numerous other things as well. Potter syndrome, again, failure of the kidneys to develop, and these are some of the identifying things that you might see over here. And then polydactyly, that's actually genetic, and it runs in families and extra digits. It might be an extra finger or an extra toe. Sometimes they have bone tissue in them and sometimes they don't. Oftentimes, a provider can just lance them off right there. Okay, and of course, cleft lip and cleft palate, that runs in the usually the male side of the family. In other words, if the father had it, the son might have it, and the grandson too. So, so when we're checking the oral nasal passages, when we put our fingers in the mouth, we're feeling for the palate. Is it all there? Obviously, you can see outside, but you have to feel and look visually inside as well to determine is there a cleft palate there. So the PKU, you might have already seen that. The phenylketonuria, oh, I can't even say it. Anyway, this is a test that's done or usually 3 to 4 days after the infant eats to determine how well it metabolizes foodstuffs. Okay, so it's a test that you fill the little circles with blood and you send it off to the Wadsworth laboratory, and for each state does numerous maybe different tests. Many are the same, but then there's a few more added for some states for various reasons. Like, for example, New York might have 100 tests and New Jersey 110. So the thing is, when they send these off to the laboratories, I often tell them, well, no news is good news. So if you don't hear from them, okay, but if you hear from them, then they have to maybe come in and have the test taken again because it wasn't done right, or they just want to verify, get this, and check this baby out a little more. So PKU, usually it's a dietary issue where if you look at the labels on a lot of the things you eat, that's in there. And these children have to be on a special diet usually for the rest of their lives. And if they're not, they can have mental retardation. Okay, so you can see here. Here's a list of some of the foods that don't have that in it. So at the prenatal office is usually where you hear the provider talk about to the patient about um, infections, and they're called torch infections or teratogenic because they affect the infant in utero. So toxoplasmosis, syphilis, varicella, rubella, cytomegalovirus, herpes are some of those that are listed there. And also listeria. We don't want to eat raw milk, soft cheeses, or any deli products or hot dogs, things like that. they have listeria in them that can affect the fetus, the growing fetus. So then also we have strep B, which group B strep, sorry, we talked about in lab and clinical before. So if the mom has GBS positive, we want to know that she's being treated in labor at least 4 hours prior to labor, so that this goes directly to the infant, because the infant can die within 24 hours of being positive with group B strep, okay, and having it affected. Early onset was in that first 24 hours. You can read the symptoms here. And then late onset could be 2 to 4 weeks. So one of the things that you'll see is the provider may choose to keep this baby a little bit, like a day or so longer, just to monitor the infant, if the mom was not treated in labor. So here it says 20% die, get it within 24 hours. Okay. So at 36 weeks, the mom is, we do the culture, okay, and she can be treated with penicillin. But obviously, we want her at least to be treated 4 hours prior to delivery. These are other things that maybe if there's a big issue, she may end up with a C-section. So diabetes is another complication of mom that can also affect babies, as it says here. Though there's increased insulin, the increased production of the pituitary growth hormone, and increases extra fat deposits in those babies. That's why they're so big. All right, but big doesn't usually mean better. They can still, the lecithin or LS ratio is what your lecithin to sphygmalion ratio. They look at how much that's surfactant in the lungs is what it does. Um, they look like they're blown up. They can be lethargic. They often come out, they have high blood sugars, but they're going to crash. So we need to take blood sugars every hour times 4, usually. I believe that's what it is. And you can read this on here. Okay, so hyperbilirubinemia, because they come out, they're so big, if they do come out vaginally, then they're pretty bruised up, look like they've been beat up. And remember, just because they're big, they still have that immature liver, so they're more prone to increased bilirubin levels as well. Fetal alcohol syndrome, well, the controversy ethically is often has been how much is too much alcohol in pregnancy. Early on, when everything's forming, it's when it affects the fetus significantly. But these are some of the identifying markers that you'll see. They're very irritable, weak suck, they're jittery, they have sleep abnormalities, and they have this typical facial characteristics that you'll see here. So what we're seeing more and more of are these babies that are addicted because of mom being an addict, or even if she's on methadone, they still come out there with some addiction. So they're small for gestational age because they don't get the oxygenation and blood perfusion. They have this undeniable high pitched scream or cry, and they can really not be consoled. They're difficult to console, and you'll see some. Oftentimes, the babies are in the incubators and the lights are down, and we have a blanket covering over the top of it just to decrease that stimulus, because any stimulus will set them off, and they're just difficult to calm down. They can have tremors. They're constantly twitching and moving. Um, and the more you touch them, the worse they are. and they can have convulsions, they can have diarrhea. So it's not necessarily a good thing. And that's my bird screaming, if you can hear him. Okay, so there's other drug issues because of drugs that maybe we give mom over the counter. King, stop that. He's going to chatter at me even more. Magnesium sulfate. So a mom may need magnesium sulfate because her blood pressure is higher, because she's contracting regularly. But one of the things that you'll see is the infant will come out being uh, decreased respiratory, because that's one of the side effects of magnesium sulfate. And terbutaline is a respiratory medication, but we don't use it as much as we used to. But what it does is, it again is a smooth muscle relaxant. So therefore, um, and what it does is it speeds up mom's heart rate, so you see baby having increased heart rate as well. So each of these medications may have some untoward effects to baby as well, the expected side effects for mom. So antidepressives, over the counters, and don't forget about those herbal medications. That's why when we ask patients on admission, what other things do you take, such as herbs? And there are many people that take um, herbal medications. So hyperbilirubinemia, remember jaundice? You see those because of the immature liver, the skin is yellow, and maybe the sclera of the eyes are yellow. And one way for the baby to get rid of that, of course, is sunlight, and we want them to poop. So we want them to get rid of that. So you can have physiological or pathological hyperbilirubinemia. Yeah, hyperbilirubinemia. Okay. So these are you can see some of the problems here, how they're listed. Okay, and this is what it means specifically. You can read that. And so oftentimes what the provider will do is they'll draw a direct Billy and a conjugated Billy. So you will see the levels on that and what that means here. So you can have ABO incompatibility. So those are the A and B remain in the mother's bloodstream. They're too large to pass, and so they leak into the maternal system circulation and go through the placenta. Once the fetal circulation antibodies cause destruction of red cells. So we can have tests that we can do for that are the indirect and the direct wounds to see if there is that ABO incompatibility. So of course we want to feed the baby because we want the baby to poop. We want to get rid of that increased bilirubin. Okay, and we also use the phototherapy lamps. And of course, baby's eyes have to be covered. We have to monitor the heat level in the under the lights, and move baby from side to side. Okay, and we want to feed baby more fluids as well. So you can see here an extreme would be a transfusion may be needed. So the transfusion, well, this shows you the lights here. Of course, we see this in the hospital. You want to have the infant's eyes covered because it can affect the retina of the eyes, and that's not good. Well, these are blankets that mom can take home. They're called Billy blankets. And so the true transfusions are done through the umbilical vein, okay? And here we're just monitoring here. Okay, and this talks about the parents and problems in let and listening to your parent. What are their problems that they're having? Maybe they were expecting a healthy newborn baby and they have this baby preterm baby with all kinds of complications now. So we have to take the time to answer their questions. Maybe put them in contact with other people that have had the same situation. Carefully explain the procedures you see in the NICU where we have the little apartment room there where parents can come stay overnight. We educate them about how to for the infant and what to expect prior to the infant being discharged and taking them home. So this shows baby here. Okay. Let's see.